Hello and good afternoon, everybody. Thank you for being here with us today. My name is Kim Mertz, and I work for the North Dakota Department of Health. And on behalf of the North Dakota Department of Health, the Department of Commerce, and the Association of State and Territorial Health Officers, we welcome you today, and we are so excited to have your commitment to be with us for the next couple hours as we talk about health equity. So, health equity, that's, a lot of people hear that word, and when we hear the word health equity, we hear health equity, we hear health inequity, we hear disparities, we hear equality. Anybody heard of ACEs, adverse childhood experiences? We hear about social determinants of health. There's so many different phrases and words when we start talking about equity, and sometimes it can get very confusing, and we can kind of get mumbled up into what does all that mean. And so today, we're very excited that we have experts here today that are going to bring some clarity to that today. Okay, so our keynote speaker, Jeanne Ayres is here with us today, and I had the opportunity to spend a little bit of time with Jeanne before today, and I will tell you that we are in for a treat because she has got so much experience and she is fabulous at what she does. So while sometimes we might all talk a different language, we maybe don't know what all those words mean, there is one thing that we all have in common. We know that health equity can be a big challenge. And how would we know that health equity is a big challenge? Well, it's not very often that we get to have the governor, that we have key leaders from different departments, and that we bring in an expert speaker from another state to talk about something that isn't challenging. So that's how we know as well that this is a really important topic and something that we really want to address and move forward with in North Dakota. So knowing that health equity is a challenge, along with lots of other challenges, this challenge, it's not just one person, it's not one program, it's not one agency or department that can really address this. It takes all of us. It takes you and you and you and you and you and you and all of us to address this issue. So we're so excited that you're here today to learn with us. But you wouldn't be here with us today if it wasn't for the fabulous planning committee that we had that put this together. So I'd like to take this opportunity to thank our planning committee. And our planning committee is Chrissy Gerard. Chrissy, can you wave to everybody? Chrissy is with the North Dakota Department of Health. She's our Health Equity Director. And we have Kelly Nagel. Kelly is with the North Dakota Department of Health, and she's with Performance and Systems. Mary Korsmo is in the audience somewhere. Mary, do you want to wave to everybody? Mary's the executive director with the State Association of Territorial and City-County Health Officials. And then not with us today, but a very important part of the planning committee was Emily Brown. And Emily is the community engagement manager with the North Dakota Department of Commerce. So one of the things that we're so excited about you being here today is that commitment that you have. Just by answering and saying, I'm coming today, you've committed yourselves to wanting to learn more about health equity. You've committed yourself to being here to meet new people, to network. We're going to have a fabulous networking opportunity after this, and you've committed to make a difference. So thank you so much for being here. I want to tell you a quick little story. I was walking over here today, and, it's kind of raining outside. And as I was walking over here, there was a mom a little girl was standing next to her, and a dad that was holding a little child. And they were walking up the steps, by the Heritage Center there, and there was like a little puddle, okay? And so the little girl's walking up, and she says, I'm going to jump in the puddle. And the mom is like, yeah. And I thought, oh, how cool. The mom's like going to let her jump in the puddle. So the little girl goes, and she jumps in the puddle. And her mom goes, yay, and the little girl took like 2 steps, and she's like, wait a minute, I didn't make a big enough splash. So she turned around, and she went back, and she jumped in the puddle again. And I have to tell you, I had a smile on my face the whole way I was walking in here, because I felt like kind of like that's like us sitting right here today. We're here to make a splash in North Dakota. Are you guys with me? Yay, okay. All right, we're here to make a splash. So I have the distinct honor and privilege to introduce you to 5 very inspiring leaders. All of them have a huge commitment to health equity and really want nothing but the best for North Dakota citizens. So first, I'd like to introduce you to Chrissy Gerard again. As I said, Chrissy is our Health Equity Director for the North Dakota Department of Health. She has over 12 years of working at state government in the health departments. She's worked not only with the North Dakota Department of Health, with the Minnesota Department of Health as well. She joined us as the Health Equity Director on August 1st of 2018, and you can't believe the amazing work that she's done already so far. When you join us for the networking and a little bit later, Chrissy's going to talk to you about this amazing document that she's put together for us. And so she's doing lots of strategic planning within the department, so we couldn't be more happy to have Chrissy on board with us. Thank you. Next is Kelly Nagel. Kelly has 25 years experience working in state government, 17 of them being at the health department. Kelly serves as our director of the Systems and Performance Division within the department. She also serves as the public health liaison and leads efforts to build capacity, improve performance, and strengthen North Dakota's public health system. So welcome, Kelly. Thank you for being here. You're going to hear more from Kelly and Chrissy after our keynote speaker today, so look forward to that. Okay, so next I have the privilege and honor to introduce State Health Officer Mylynn Tufte. Advancing health equity is not only a passion of Mylynn's, but a priority to the departments to improve the length and quality of life for North Dakotans. Mylynn has over 25 years of experience in healthcare. Her firsthand knowledge of caregiving as an ICU nurse has helped shape her passion for healthcare information systems and technology. Mylynn's diverse experience includes population health, innovation, and strategic advisory work with our nation's largest payers and providers. Mylynn was appointed by Governor Doug Burgum in 2017. Unfortunately, Mylynn had a conflict and couldn't be here today, but she sent us a recorded message.
Thank you so much for attending the Health Equity Symposium. I'm so sorry that I cannot be there with you today. I hope you have a great evening, and I really appreciate you attending this event. I know it's going to be great. At the Department of Health, we are committed to the mission of improving the length of life and quality of life for North Dakotans. This is part of our purpose as Team North Dakota to empower people, improve lives, and inspire success. Some of the strengths that North Dakota has achieved are our low levels of low birth weights, our great air quality, our low levels of violent crime, as well as achieving high immunization rates with high HPV immunizations. We know that we've made great strides in our strengths, and we have some areas that we can improve upon. This includes binge drinking, high levels of obesity, as well as occupational fatality rates. We're working with DOT and Highway Patrol on an initiative called Vision Zero. Vision Zero is working to decrease motor traffic fatalities on our roadways, and we're making strides to make improvements in this area. One of the areas that I'm really excited about for North Dakota is the President's Challenge. This is building healthy and resilient communities, and I think the Health Equity Symposium, as well as the Main Street Initiative that you'll hear more about today, will help us improve the work that we're doing. As we think about the social determinants of health, the areas that we live in, these communities where we work, play, and grow, they impact our outcomes. Our length of life and quality of life, they're so important to what we do and how we live that I think that today will be so important. And I thank you for your investment of time and your engagement and the work that you're doing for North Dakota. Thank you.
Thank you, Mylynn. We know that Mylynn really wanted to be here with us today. She's a true champion for health equity and just for public health in general. So next, I have the privilege of welcoming Commissioner Michelle Kommer. Michelle Kommer is the Commissioner of the North Dakota Department of Commerce. Michelle serves as the Interim Labor Commissioner and previously served as the Executive Director of Job Service of North Dakota. Michelle has more than 20 years of experience in the private sector, leading human resource, operational, and legal functions in the financial services, health insurance, and energy and manufacturing industries. Michelle received her undergraduate degree from Mayville State University, her master's degree from the University of Mary, and her law degree from the University of North Dakota School of Law. Outside of work, Michelle has been a passionate advocate for child welfare in North Dakota, both as a foster and adoptive parent, and in founding a nonprofit organization, the North Dakota Heart Gallery, to promote awareness of the need for adoptive families for North Dakota children. Please help me welcome Michelle.
Good afternoon, everybody. I am really thrilled to be here today. I was so happy to be invited. It's an honor to take part, and I want to thank all of you and Mylynn, the team at the North Dakota Department of Health for this invitation and for your efforts to advance the health of North Dakotans. So there may have been a time where one would have wondered why the Department of Commerce would be invited to participate in a conversation like the one that you're having here today, and I'm really happy that that time is no longer. Under the leadership of Governor Burgum, who not only encourages but expects cross-agency collaboration, it is an immense privilege to collaborate with my colleagues on matters that are important to North Dakota, and the intersection of commerce and health is one of those matters. So let me begin by describing a little bit about the North Dakota Department of Commerce and our current priorities. The Department of Commerce is the lead agency charged with growing our state economically and improving the quality of life for our citizens. Our 4 divisions include tourism, economic development and finance, workforce development, and community services. It's well understood that as the economy of a nation improves, so does the health of its citizens. But what may be less obvious is that the opposite is also true. Improving the health of a nation's citizens can directly result in economic growth, for the simple reason that there will be more people to advance their education, participate in the workforce, build businesses, and consume products and services. In fact, in preparing for this evening, I was telling Jeanne a moment ago, I'm a little bit of a data geek. I like to research, I like to understand, I like to know what's happening in the nation and other states, what other folks are doing. I learned what I understand to be an old adage, you may have heard it before, I had not, and that is this: health before wealth. It's a theory that proves the connection between health and commerce. This truth is recognized by this administration and incorporated into the Department of Commerce's focus for the future, where our priorities include these 3 things: economic diversification, community building, workforce development, and retention. And I'm sure those priorities come of no surprise to you. The 3 priorities are inextricably linked. Each requires the other, and no one of them can happen alone. And each has a direct link to the Main Street Initiative, which the governor will speak more about in a moment. Speaking of the Main Street Initiative, though, I have to tell you a few things about that. It has been a vital part of the work of the Department of Commerce for the past 2 years. And like I said earlier, I'm a data and a process geek, and I like to turn everything into a math equation. So the math for the Main Street Initiative is this: healthy, vibrant communities, plus smart, efficient infrastructure, plus a 21st century workforce equals a strong North Dakota economy and future prosperity and health and growth for our state. Our Main Street Initiative team is working with local leaders daily, literally, to shape the future of the state by facilitating resources for communities and providing the tools that help businesses grow and for communities to thrive. Job creation was once where we focused our economic development efforts, but today we know it's not enough to just create jobs. We need to build strong communities so that we can attract workforce and their families to live in North Dakota. This is supported by a whole bunch of studies, which I enjoy a lot. A Harvard study recently showed that people tend to move to cities with plentiful amenities. Governor Burgum will speak more about those things in a moment, like access to quality medical care, wellness amenities, parks, walking paths, all help to differentiate communities. U.S. cities with more amenities have grown more quickly per capita over the past 20 years than others. The creation of strong communities also has a positive domino effect, in other words, momentum. The same study's author says that there's a very strong track record of places that attract talent becoming places of long-term success. And I also like this quote: "The most successful economic development policy is to attract and retain smart people and then get out of their way." So while job-related considerations are important factors in the decision to choose a new community, quality of life amenities can be the factors that ultimately lead people to move. So just a little bit about Main Street in action. Creating healthy, vibrant communities is no small task. The success of this effort requires state and local leaders, along with committed residents, and support systems like all of you. Communities are engaged and starting to show the tangible benefits of the Main Street initiative. So far, there are 63 communities representing 85% of North Dakota's population engaged in the Main Street initiative. And I want to tell you just a story that just came up yesterday. We have a team that was in Gilby, North Dakota yesterday with a population of under 300, in Thompson, North Dakota today, but this story is from Gilby. When the Main Street team showed up, there were about 45 people in the room, which if you do that math represents about a fifth of the town's entire population. This was a community that cares about the community. This is a community that cares about sustaining the community. 2 tables in that room were students, youth that were engaged in the process. And it's examples like that that give me a lot of energy and a lot of hope for our future, for our state, for economic health and wellness, but for every type of health and wellness. So a few other examples before I turn the stage over to Governor Burgum. As part of the Main Street Initiative, we have seen several communities recognize the importance of health in their community and as part of the Main Street Initiative. Jamestown, is anyone from Jamestown? No? Jamestown has a program called Get Fit and Explore. Central Valley Health partnered with Jamestown Tourism Talking Trail to create Get Fit and Explore downtown walking route. That's just one of a number of local efforts to improve health. Stanley, North Dakota developed the Stanley Sports Complex project. Community members spent several years raising the funds, showing great pride in their community and improving opportunities for youth development and healthy activity. The complex there is a local attraction and an asset to that community and surrounding communities. Of course, Grand Forks has developed the Mayor's Vibrancy Initiative, which has supported the development of projects that will elevate the local quality of life for years to come. The projects included in the plan are public art, investment in parks, efficient infrastructure development, and other improvements. These are just a sampling. We have healthy community projects happening in Hazen, in Bismarck, Beach, Bottineau, Oaks, Wahpeton, Grafton, and Hettinger, and the list goes on and on. The rest of the country is starting to take notice. We have been named the #1 state for young adults and millennials in the United States. U.S. News & World Reports recognized us last year as the #1 state for quality of life. An emphasis on quality of life and livability helps to attract workforce, drive the state's economic growth, and make the state an obvious choice for those seeking diverse opportunities. Building healthy communities is vital to building a strong and resilient economy in North Dakota, and I'm thrilled to be part of the collaboration that is happening every day across cabinet agencies, across professionals, and throughout the entire state. So to close, I just want to say thank you, and thank you to the governor for his leadership. It's so wonderful to be part of a team where we work as one, and I look forward to continue opportunities to work together on this important work. And a final note, I want to thank the folks at the Department of Health for your adoption and leadership of the Be Legendary brand, unifying, I made it, it's not a, is that funny? There's a joke. That was a knowing laugh. Later, I'm going to figure out what that was for because I want to hear the story behind it. I appreciate that. No, but I do sincerely thank you for that because a unified presence as a statewide entity is so, so important to making the most of our resources. And we just really do appreciate your leadership there. So thank you very much, and thanks for allowing me to join you today.
Thank you, Michelle. I don't know about you guys, but when I see like the video that Mylynn had made for us and I hear Michelle talk, it makes me excited as a state government worker and honestly as a citizen for North Dakota to think about the direction that North Dakota is going. It's really an exciting time for us. So thank you so much for your leadership. And you know, leadership at the cabinet level is so important, but good leadership at the cabinet level is directed higher than that even. And we are so very fortunate to have Governor Doug Burgum with us today. Doug Burgum took office as the 33rd governor of North Dakota in December of 2016, bringing a business leader's approach to diversifying the economy, creating 21st century jobs, and revitalizing our main streets. Burgum helped lead Great Plains Software from a small startup company into an award-winning tech firm that employed thousands of team members from more than 220 cities across the state. Following Great Plains Software acquisition by Microsoft in 2001, he remained at Microsoft as the senior vice president through 2007. In 2006, Burgum reaffirmed his passion for North Dakota by founding Kilbourne Group, a real estate development firm committed to creating smart, healthy cities through vibrant downtowns. The company's substantial impact on revitalizing downtown Fargo is what inspired the Main Street Initiative, which was built on 3 pillars: the healthy, vibrant communities, the smart, efficient infrastructure, and the 21st century workforce. Let's show Governor Burgum how excited we are to have him with us today.
Thank you. Good afternoon. Thanks everybody for being here. And I want to thank Kim. Thanks for that nice introduction. Michelle, Mylynn. Some of you think M&M is a candy. Others probably think it's a wrapper. But M&M is Mylynn and Michelle. That's for me. They got two great leaders getting great stuff done and working together. And for Chrissy and Kelly and everybody else part of Team North Dakota that's here today, all the team members that are here, thank you guys for everything that you do. It is an honor. So on behalf of First Lady Catherine and Lieutenant Governor Brent Sanford, we're honored to be here today, but honored to have a chance to work alongside of all of you and honored to have a chance to serve North Dakotans on what we do. I've been asked to talk today about health impacts, and of course there are 100 things that impact health, and there are lots of national discussions going on about insurance models and approaches and role of government and all that. But today I'm going to try to stay narrow and talk about the impacts related to community and community design and how those designs impact health and focus on that element today. And I know that other speakers and Michelle touched on other things, and I'm sure Jeannie's going to talk about other aspects of this, but I want to focus on that. But like I say, to start, let me just begin with gratitude, because there are many of you in this room that are here, and I recognize that are working at the county level, the commission, city commission level, people that are working here for Team North Dakota in the state, that you're working every day to try to lead to a healthier North Dakota, and I'm really grateful for everything that you've done and are doing, because we have an opportunity to differentiate ourselves as a state. I mean, as a small, nimble state that has incredible resources. I mean, we're really in a time of abundance. You may hear otherwise sometime, that people try to carry forward this 1930s scarcity mentality, but in North Dakota we have an abundance of talent, abundance of information, abundance of financial resources. What we're probably short of is workforce, and we're short of bold and courageous leaders that are willing to create a vision. And so those are two things we're short of, but we can make up ground on that. And certainly we got things to celebrate. I want to say, in addition to gratitude, I want to say congratulations. We did move as a state from number 13 to up to 13 from number 18 on America's Health Rankings, and so that was a substantial move up. I think we're in shooting distance of being a top 10 state, which would be a great place for us to go next. But there are some things as part of this conversation and as part of the thing that we have to do that are holding us back. Of course, addiction is something that touches every family, every community, every organization in our state. It's got a tremendously high cost, and the cost is really unknown. When we went through strategic planning for 57 different strategic agencies in North Dakota prior to this introducing our executive budget last December, in that process we had templates that went out to all the organizations. We said, is your organization impacted by the disease of addiction? And it turns out that the majority of them filled it out and said they absolutely it did. A few of them didn't. Once we had a conversation with them, we realized, oh yeah, it actually does affect our organization as well. And you think about the highway patrol and the work that they do in terms of life safety and keeping our highways safe. Every traffic stop puts our brave troopers at risk because of who might be driving the car, what they might be transporting, and what's going on. So it's a big impact there. Leanne Birch and the great work that she's doing in corrections. We've got over 80% of the men that are incarcerated in our system they may be co-reporting on other issues, including behavioral health, but over 80% have substance abuse disorders. In the women's prison, it approaches closer to 100%. In the youth, it's closer to 100% that have had interactions with substance abuse. And so it touches everywhere. Then you think, okay, well that's obvious, but what about Parks and Rec? Well, Parks and Rec has nothing to do with that. Well, Parks and Rec has uniformed law officers that patrol our parks. We have hundreds of thousands of visitor nights in those campgrounds, and you start talking to the park rangers. Oh, well, what do you do? Oh, we've got, domestic disturbance. We got all these challenges. We've got, petty theft. We've got whatever crime, whatever. What's it related to? Well, usually it's related to addiction, disease, et cetera. So you can just start going through every agency. K-12, number one request from our K-12 schools across the state is more behavioral health resources related to the challenges that they're having in the schools. So there isn't any part of our state that's untouched by it. But from an accounting standpoint, we have two agencies that actually have a line item related to it. Human Services has got elements related to treatment. Department of Health has got elements related to prevention on the disease of addiction. But we have 55 other agencies that do not have a line item related to it, but they have cost. So when I'm saying it's an unknown cost, I'm not just saying that as a euphemism. I'm saying as if you're the chief executive of the state and you ask somebody, hey, we're going to spend $14.3 billion in the next biennium related to the disease, across our state, how much of a cost is related to the disease of addiction? Nobody knows. We don't know. I know the number is hundreds of millions of dollars. It could actually approach $1 billion. I mean, it could approach 1/14 of our budget across 57 agencies are affected by this. And if you think that that's not possible, then remember that we're a state that we're 13th overall, but we're 49 out of 50 states on the prevalence of excessive drinking. We're 44th on occupational fatality rate. We're 38th on obesity, and obesity is going up, not down. It's increased in the last 11 years. And so that's not good, and we've got opportunities to work forward. And of course, I'm deeply grateful for the First Lady and everything that she's doing to try to reduce the shame and stigma and having courage to talk about her battle with the disease of addiction, because we have to normalize the conversation. If we, treated addiction, if we treated addiction the way we think about diabetes or cancer, I mean, you would never tell someone who had diabetes, look, I gave you 28 days of insulin. What's the matter with you? You relapsed? You're a complete moral failure. And let's pile on a bunch of shame and stigma around that. We would never do that to someone because we understand that diabetes is a chronic, progressive, ultimately fatal disease if not treated. And that's what the disease of addiction is it's chronic, it's a lifetime disease, it's progressive, it's ultimately fatal if not treated. And so that's why, all the work we're doing to make improvements in our correction system is because we can't spend $41,000 a year incarcerating people and not addressing the underlying problem of why they're there, which was the disease of addiction, because we can do that for a fraction of the cost. And that's why the great work that's been going on by Pam Sagnis and the Chris Jones and the Human Services Department, and everything we're doing with Free Through Recovery to try to move people, out of the correction system and into a system that helps support them around both the community and social determinants of health. And in one of the previous slides that Mylynn had up, she had these plus the elements, important ones related to food, but in access to health care, all these things matter in terms of how we're trying to to drive that. And today I want to talk about some of these that, again, they're more related to Main Street, which is going to be more related to how we build our cities, walkability, transportation, and vibrancy, but understand that all these other elements do matter. And just when I touch on food, which is not on here, I mean, one thing for us to think about, we do have parts of North Dakota in the rural areas that are food deserts, and that's not good. I mean, from a health standpoint, we know that nutrition is a key part of it. So it's something that we have to work together. But we pride ourselves on being this agriculture state. We're, you know, number one in 11 crops, you know, all this stuff, ag. You know, when our forefathers and ancestors were here, there was a lot of food production that was grown in gardens. There was a lot of canning. There was a lot of things that happened. There, a lot of the food that we ate was grown here. And now you go to a grocery store in a place where we don't have a food desert in January, and you want to buy some blueberries, and you look at the label, they might have come from Chile, they might have come from El Salvador, and it's great that we've got a global supply chain for food, but if people are concerned about, you know, food production, where it comes from, the energy cost of transportation, and then here we are in a state that's got enormous resources around agriculture in terms of the people that know how to grow things and the soil that we have. We have some of the best soil in the world, and then guess what? We've also got some of the most abundant energy in the world. And there are places that are much smaller than North Dakota, including Iceland, which has only got 330,000 people out in the middle of the Atlantic, has got using their thermal energy in their greenhouses to be self-sufficient in food. And North Dakota, you know, from all year long, we're not self-sufficient in food. If there weren't trucks of food coming into North Dakota to feed us, we'd all be starving to death, because I don't think we're all not going to you know, eat raw corn and raw soybeans, because we grow all these crops. We're number one. We load them on trains, we ship them out, and then we whine when we got an issue with our biggest customer, you know, like China, as opposed to us taking more control, more value added, and more local. But we would have an opportunity here, taking the energy we have and the technology around greenhouses. Instead of being an ag producer 5 months a year, we could be an ag producer 12 months of the year. And what could that mean? Instead of having farmers markets, you know, for 3 months in the summer, like, well, that was fun, it's over. You know, we could be having farmers markets with fresh food all year round. And because guess what? People actually do this on our planet. We actually don't even have to import ideas from other planets. We can just copy ideas from the same latitude. And you want to know who's one of the groups leading on this? MHA. MHA, Chairman Mark Fox, one of the great energy producing tribes in the nation, just got back from taking a delegation to the Netherlands. The Netherlands, small little country, food exporter, and they're a food exporter because they're growing food year round, hydroponically in greenhouses. And of course, we've got universities, we've got the ability to do research, but we're stuck in a mindset of, you know, grow large commodity crops and ship them out of here. But I guess we do produce our own flour at the state-owned North Dakota mill, so we would at least have that here. We'd have some flour. Man does not live by bread alone, but we could maybe try that as our one value-added product. Okay, anyway, so we have these social determinants of health, but let's talk about Main Street. The three legs of the stool on Main Street: healthy, vibrant communities, smart, efficient infrastructure, and 21st century infrastructure or 21st century workforce. Sometimes we show these as a triangle, sometimes as a circle. These are all interrelated, and they all interconnect, and they're all dependent on each other. And today I want to talk more about healthy, vibrant communities, but understand that they're all tied together, because one of the ways that we create healthy, vibrant communities is we're smart about how we do the infrastructure, and we start thinking about building and designing cities for people, not for automobiles. And 21st century workforce, this is a very interesting time to be alive in our country. It's the first time in the history of the United States where there are more jobs available than there are people seeking jobs. And this requires us to think completely differently about just about everything, including how we approach licensure. We have over 80 groups that do licensure. Licensure has been about, you know, during periods of high unemployment, there's been a component of, yes, it's about consumer safety, but let's be honest, it's also about protecting the jobs of the people in that licensure category. And we've won a major battle to have one of our first breakthroughs in licensure. We're moving towards having trailing military spouses that would come to either Grand Forks Air Force Base or Minot Air Force Base if they're licensed in another state to have reciprocity. This would be fantastic. When Vice President Pence and First Lady Pence were in North Dakota, the First Lady of North Dakota and the Second Lady of the United States were meeting with military spouses at Grand Forks Air Force Base, and they heard from someone who'd been a licensed addiction counselor for 18 years, but could not practice in North Dakota, and we have hundreds of positions open in that example. We have teachers, we have nurses, we have people that could be contributing. But here's the thing that I'll also share, again, more bluntly, is 80 to 90% of trailing military spouses are women. So denying trailing women access to do their profession in our state, in my mind, is also has a degree of gender discrimination included in it. And we have an opportunity to eliminate that, and we also have an opportunity, which is because military families are often two-income families, and if the spouse can't get a job here, and that spouse happens to be the mother, and the mother happens to be having more of the parent and child-rearing responsibilities, someone on orders may move to one of our Air Force bases, and the mother stays home in another state where they can continue to work as a teacher, a nurse, an addiction counselor, whatever it happens to be, and then the kids don't move here. And then the second the orders are done, that military spouse packs up and leaves North Dakota. If we actually had them both here, they might go, wow, great schools, great communities, great health care, great things to do. They'd stay, and then we have 2 more people in the workforce, and we have kids that grow up here and move and live in our communities. So we're really missing an opportunity. And if you say, wow, that's just mind-blowing, we're going to actually take that kind of risk that we would let military spouses work in our state with reciprocity, whatever state license they have. Take a look at Arizona. They just passed a law where if you're licensed in anything in any state, you can work in Arizona. And they just why do we need licensing boards? Everybody else in the nation has become so restrictive, there's not a chance that if you have a license to braid hair in Kentucky, that you're going to injure somebody braiding hair in Arizona. So if you can walk a dog in New York City with your license, which you need a dog license and you don't need one to babysit kids, but you need a dog, in some states you have to have a license to be a dog walker. But anyway, if you've passed those licensures in other states, in Arizona you can move there. You know what that's going to do? People are going to move to Arizona. Arizona has jobs open. We're competing with every other state for jobs, and that's part of how we build, vibrant, healthy communities, is we actually, attract the workforce. This all comes together. So anyway, but on the healthy, vibrant communities, just so people say, what do you really mean? We're talking about everything. Quality of life, which is exciting. Michelle mentioned we're #1 U.S. News and World Report. Arts and culture matter, and not just for adults. It matters for kids. It matters for school programs. It matters for engagement. Diverse dining, entertainment, and retail. People will move to certain cities now based on what the food culture is in that community. And retail has to be local and differentiated. Nobody is going to move to North Dakota and live here because we have a Sears or a Kmart. Oh, that's right, they just closed. No one's going to move here because we have a Best Buy. They're struggling to stay alive. No one's going to move here. I mean, the competition for 20 years about cities was who could get the big box. And I don't just mean the large metros. The small towns are fighting over Shopkos, and they're all closing. Retail is completely being disrupted by technology, and we spent enormous amounts of economic development energy trying to attract big box retailers as an economic development strategy. Those were placed along corridors of multi-lane roads that often were the result of federal dollars coming into our communities for things like US Highway 83 here in Bismarck, or Business Loop I-94, which is also US Highway 10. If it's got a US designation, you get 80% federal dollars, and that's how we end up in a state like North Dakota, in cities across the state, where we end up with places where you have roads that are 7 lanes wide with 2 lanes of in frontage road to support the retailers because the 7 lanes are too wide. And we're living in communities of under 75,000 people, and we have places where we have 11 lanes wide, which we get to plow and patrol and maintain and whatever, and we take the federal dollars because it's an 80% match. And if you ask the local city commissioners, here's 80% of this thing, what would you do with it? None of them would build none of them would go, I got an idea, let's build 11 lanes wide. No, they would be building, bike paths and community and supporting art. They'd be doing all kinds of stuff if they had the money, because they would know that's what the community need. But when we take the federal dollars and apply them to communities our side in a highly rural state, we end up with some really odd outcomes. And we have to just take a look. And one way to take a look is whether or not you're driving on a federal road is look at your speedometer. If you're going 60 miles an hour or higher, you're on a road, that's probably most likely funded by the state. If you're 25 or under, you're on something that's called a street. They're generally safe for pedestrians. The lower the speed, you can, and hope no one ever gets hit by a car, but if it's below 25, you have a pretty good chance of living. If it's over 35, your mortality rate just drops to almost nothing. So there's a big difference between 35 and 25 and under. And whether you knew that or not, your body knows it, because if you're walking next to a street where the cars are going 35 or 40, you're uncomfortable and you don't shop there. If you're walking on a street that is super slow and traffic's jammed up, and from a traffic engineer standpoint, it would look like a nightmare, that's probably the place that's got the highest sales per square foot of any place in your city, because it's a safe, walkable retail neighborhood. And when you go to other cities, you probably go, oh, I love this place, it's so great, we're walking around, we never got in our car all day, it's great. You're probably on really less than 25 mile an hour, historic, narrow, walkable neighborhood streets. You were not in a big box retailer that you could shop at home and do that. So anyway, we have to take a look at the relationship between roads and the economics of cities. But that all adds to that thing when I'm talking about retail ties back. But health, safety, walkability, all those matter. Cost of healthcare, we know this is a huge number in our country. 3.5 trillion, that's a 2017 number. This thing is skyrocketing towards $4 trillion. $4 trillion with a T. So that's a trillion is 1,000 billion, in case people are wondering. So that's would be like $4,000 billion annually that we spend on healthcare in our country. And that's almost 11,000 per capita, but almost a fourth of that 4 trillion relates to things like diabetes, like chronic heart disease, like obesity. A fourth of the cost is related to things that go away if we have a more mobile, less sedentary society. And it doesn't even involve going to the gym and working out really hard and getting into zone 5 on your heart rate 3 times a week. It just actually means walking. If we compare ourselves, our healthcare systems, to European countries or other places, and we go, wow, we spend more than they do, and theirs is lower because it's socialized. I mean, no, theirs is lower because people are, in Copenhagen, over 50% of the people commute by bicycle year round. And they're at the same latitude we are, but they've actually built so it's actually safe to commute that way, and culturally it's supported. And part of it is how people do mobilization. We do mobilization one way in our country, and that's by automobile. We don't even do mass transit well outside of a few major metros. I mean, it's all about that. But we've got an opportunity to save $1 trillion if we think about designing our cities differently. And this scales, it's not just Bismarck, it's like down to even the smallest communities. Even our smallest communities in North Dakota are doing things where people that live in those towns have to drive to get to their downtown, even in a community of 1,000 people, because we have not designing that way. So the transportation, they're talking about here, it's parking. If anybody wants to read a 750-page book by Don Shupp, you can, or you could skip it, and I'll give you the cliff notes, the title is called The High Cost of Free Parking. There is more parking surface area, now I'm not talking street parking, I'm just talking about parking lots. There are more parking lots in the United States than Connecticut. The value of the land under those parking spots is more than the sum of every car that every American owns. The parking on a balance sheet is higher than the car. If you're driving into a parking lot, and depending on the parking lot, the cost of if your car is worth less than $20,000, there's many places where you're parking where the spot is worth more than your car is. And what do we expect? We expect, living in North Dakota, that when we go to church, when we go to the grocery store, when we go to the YMCA, when we go to see our kids' school program, when we go to a chain restaurant, when we go visit our friends, we expect there to be free parking everywhere we go. And if there's not free parking, there's something wrong with the way the community is designed. That's a cultural expectation that we have, that there ought to be 10 or 15 free parking spots for us available at any time. And if you have to actually drive around because the lot's full, or you can't see the door from where you park, now we got real problems. Because this is an expectation that we have. And we have to think about that expectation as a state where we've got healthcare issues, obesity issues, diabetes issues. We got to start thinking about having a culture where if I can't see the door from where I'm parking, that's a good thing, because that means I might get in 100 steps or 200 steps. And I mean, and it's an interesting cultural thing. In downtown Fargo, there are people that say they will not come to downtown Fargo because of the distance they have to walk. We did an overlay of West Acres Mall on downtown. Most people that park at West Acres walk further to get to the door of the mall than they would walk anywhere in downtown from any of the many available free or city-owned parking lots, but they can't see the door from where they park. So apparently that's key to our thing. We got to be able to see that door out there. Anyway, so the high cost of free parking, the other part of the high cost of free parking is that when we have parking in retail areas where we don't have turnover, the value of turnover in a parking spot can be worth as much as $80,000 a year to the retailer. Because if someone's going to park and they park for 4 hours, or the store owner parks there for 4 hours as opposed to people that are, moving in and out. So we have to think about, what are the mechanisms that allow us to be able to have turnover in shopping areas and have that be a different need, because that's also can help drive sales tax up. But the thing that's interesting, there is a cultural change. I've got 3 kids that are 25, 23, and 20, just turned 23 and just turned 20. They grew up in car seats. I hauled them everywhere. I mean, everybody's like for a while there was 3, then there was 2, 1 in the front, 2 in the back, 1 in a booster seat, and you're hauling them to this practice and theater practice and soccer practice and doing whatever. And guess what? Now they're starting to realize they don't want to haul their kids around in car seats. It's like, why would they do that? Millennials all over the country are buying cars at fewer rates than ever before, and they're doing that because there's a thing called collaborative consumption. Most of us grew up with the idea that you not only need 1 car, you need 2 cars, and if you live in most places in our state on the edge of a larger city, you got to have 1 for you, 1 for your spouse, and a car for the kids. So there's a lot of people that have gone down that path, and then transportation costs are huge. I mean, 1 car can chew up 18% of a family's budget. And then we put people in the position. I've said on some of these suburban areas that are out on the edge, there ought to be a sign out next to them that says, when you're here, don't just check your mortgage and the interest rate. If you live here, you will need a car for you, your spouse, and any children that achieve driving age. So be ready for that, to do that. But we have people that are moving back into older neighborhoods, younger children moving back into older neighborhoods. That's happening all over the country. It's coming to North Dakota. And we have people that are using collaborative consumption. Think of it as, if everybody grew up like I did in a small town, you know what custom combining is. Combines come rolling through from Kansas, Nebraska, South Dakota, North Dakota, and they're there, and somebody pays them to harvest their grain for a week, and then they're on moving into Canada. And so they don't have to buy a $600,000 combine. They just use it for the week they need it. Collaborative consumption is what Lyft and Uber is all about. And I know the headlines are all about, Lyft's IPO is slightly below its opening price. How about Uber's market cap is higher than General Motors? Uber as a company has more value than General Motors. They don't own a car. How about the fact that Airbnb and every other, Airbnb, VRBO, HomeAway, and all those companies that are just software, they don't own any hotel rooms, their valuations is higher than many hotel chains, and they book sometimes millions of homes per night, which is more than virtually every hotel chain combined. And that's all happened in the last 10 years. Because everybody's walking around with a supercomputer in their pocket. So we have to build communities. I mean, 10 years ago we were trying to figure out, let's have a one-to-one school, and we'll have a thing called a cow, where we'll have computers on a cart that rolls up and down the hallway because we can't afford to buy a computer for every kid in the school. I mean, that was a real thing, like 8 or 10 years ago. The cow, computers on wheels, we're going to share computers. And now every kid walks in the door, with a supercomputer in their pocket called a smartphone. It's got more power than, the smartphones are probably more power than the things that we put men on the moon with. And so we just have to understand that's going to disrupt everything we do. It disrupts education, it disrupts healthcare, it disrupts health, it disrupts transportation, it disrupts the hotel industry. Online retail shopping is disrupting big box retailers. And guess what? When it disrupts transportation, all these things have to disrupt how we build cities. But we're still building cities like there's no collaborative consumption. People don't have supercomputers in their pockets. They want to live in the same size house that their grandparents did. I mean, we're just moving along on momentum as opposed to understanding there's cataclysmic shifts that are occurring that are happening, and some people are need to do it. So this is all about designing for people, not for cars. Let me just give you one number if you think this isn't important. The federal matching grants on this stuff, where they say, oh, we're doing stuff for mobility and we're helping out on these other stuff, it's like 1.8% of the Fed money goes for stuff that's non-automobile. That means 98.2% goes towards automobiles. And so then, do you think our nation could get by on 96% going to automobiles? We could double what we were putting into bike lanes and safe transportation for walking. You know, that would transform, I mean, communities would be like, wow, I want to live here, man. You guys got bike lanes everywhere. And they're not just a bike lane that's a piece of paint. If you put a piece of paint on one of our 35-mile-an-hour one-ways and do a study, you know who's going to ride bike on that? 18 to 24-year-old kids whose brains aren't fully developed, who have a high tolerance, or either they're risk-seeking or a high tolerance for risk. And you think I'm making stuff up. This is actual social studies. You will never see a mom pulling a burly with 2 kids down a thing that's protected by a piece of paint between people driving 35 miles an hour. You will never see that. But if you put together a protected bike lane that's set aside, maybe it's protected by a row of parked cars, maybe it's protected by guardrails, whatever. If you create protected bike lanes and build them like they've got them in other major metro areas and cities where you got 50% of the people commuting, guess what? You will have young kids, parents, people pulling burleys because it'll be safe. You have to design. There's a design element. It's not just about, oh, we're going to share the interstate with somebody on a bike. Let me talk about walk scores. This is a simple way to evaluate communities if walking matters. The Costco is a development in Fargo, highly sought after big box retailer out by Veterans Boulevard. This is in a little older picture because there's a little more development, but a walk score, you go online, it's free. You type in any address, you come up with a walk score. The lowest you can get is 0, the highest you can get is 100. If you're above 80, that means that you can live in that spot without an automobile, and you can walk and get groceries, you can get health care, you can get your hair cut, you can go to a movie, you can go to a restaurant, you can do all the things that you could do that you'd want to do in the course of a normal week of living with you and your family and not have to walk. But when we move to the edges of our communities with sprawl, with big box retailers and federally funded roads like Veterans Boulevard, got some federal funding next to there, which is a big wide 6 or 7 lane wide kind of thing, which attracts big boxers, which then attracts traffic, which then people sit at stoplights and then they complain because there's too much traffic and you should build more lanes, and we build more lanes and that attracts more cars, and then the wait times are longer. It's called induced demand, okay? You try it sometime. Take something that's a 2-lane, turn it into a 1-way, and increase the speed, and you'll end up with so many more cars that transportation times could actually go down. So the things that we cling to, like the 1-ways here in Bismarck or the 1-ways in Fargo, whatever, we cling to them because that's what we've known, but there's actually not evidence that they get you there faster or safer. And then guess what? The property values along those go down because nobody wants to live on a street where people are driving that fast. So we actually take our neighborhoods and slice them up with things that we thought was a modern idea built around automobiles. Because if you're building around people, you wouldn't have those. You wouldn't have those. It's like the automobile is in charge. Of course, we're going to have 1-ways. Why not get rid of all the stoplights and raise the speed limits? I mean, so those are all things. Anyway, here we have the Heritage Center. So when government takes a large block of land like this and doesn't develop it, then we get low walk scores, so government can even do it. But you get into the downtown areas around Bismarck and Fargo and others, in Williston even, a small business in downtown Williston, 75 walk score. Downtown Fargo, Birnbaum's have great bagels. They got a great national review for that. They're at a 95 walk score, getting close to 100. Grand Forks has got some areas downtown, including Grand Forks Central High School. This is one of the highest walk scores of a high school in the state. We looked at all the schools because the old ones that people want to shut down have high walk scores and they're in great walkable neighborhoods. Even Bismarck High down the street here still got a 67. And then where my daughter had an opportunity to go to school was Davies High School. This is a little bit older picture because it's the most thing that's available on and we're not missing any digits. She graduated from college last year. She started here when Davies opened. She was a sophomore. So that was 8 years ago when she started to go to school there. 2 years before that, they started construction 2 miles out of town. 10 years after construction, Davies High School is a 0 walk score. That means you can buy nothing within 1 mile of this place. You can't buy a candy bar. You can't buy you can't buy anything near here. So this is school districts deciding to buy cheap land on the edge, going to the edge, $53 million of infrastructure, caused the city of Fargo to have to hire 45 employees, 21 firemen and women for the new fire station, 24 new police to man 8 new squad cars times 3 shifts to man that. So there's a 45 new full-time pension earning government employees to support this sprawl. And when it's all done, and the only thing that's going to be around it is single-family homes, because it's filling up with single-family homes now, but you can't walk and knock on someone's door and buy something. So they're all single-family homes, zoned single-family, because zoning is another American thing, developed during the 1910s and 20s during the Industrial Revolution, where we said, oh, industry bad for people's health, so industry has to be here, and residential's here, and retail's there, and you're going to work here. And you know who really benefited from that? People that build roads and cars, because everybody had to drive to get all the functions done in a day. And all the cities that were built for the prior 5,000 years before that actually had mixed uses, where people could work, live, play, and do that within a certain area and did not require an automobile. That's an American invention, single-use zoning and cars, and it all hurts health. So anyway, this is, if you want to have an economically viable city, then you need vibrant cores. The green bars here, this is an illustration of Fargo. The higher the bar is the green bar, the more there is tax revenue coming off that particular square foot or that acre. And so when you've got areas like older, dying downtowns, they're actually the cash cows which are supporting the money-losing red on the edge. And so people have tried to argue that the downtowns are getting subsidies. It's actually the opposite. The older downtowns with higher property value per linear foot of infrastructure throw off cash and support the growth on the edge. The older parts of Bismarck have 1,400 people per square mile on water meters. The edge has 440 water meters, residential water meters per square mile, and everybody pays the same for a gallon of water on your water bill. So we know who's getting the subsidy. The edge is getting the subsidy, whether it's streets, roads, water, protection. That's where the edge is. Well, one of the things that we did is we said, as part of the Main Street Initiative, we want to make sure that we try to help all of the people, because we have no full-time mayors in North Dakota. We have no full-time city commissioners. We have very few even full-time city managers. We said we want to try to get information out. So these won a national award last year. These are evolving and moving. This was an earlier version of one for the city of Ayres in North Dakota. But we're taking data from over 40 sources and putting it out so that you've got a dashboard. So if you're a part-time mayor in a small town, you can actually look at the data and try to make more data-driven decisions about the next investment you make in terms of smart infrastructure, because where you place the school and what you do with the infrastructure affects walkability, and walkability affects health, and that's what this whole talk is all about. So anyway, Charles Marone, on Strong Towns, I'd recommend anybody that wants to build healthier, more tax-efficient communities to think about, strongtowns.org. They got podcasts, they got blogs, you can sign up for a newsletter, they hold conferences, really a great resource. And he's from Brainerd, Minnesota. He understands the size communities and the culture of the communities that we have in North Dakota. And as he says, they do not create wealth, they destroy wealth. And what that means is the taxes that are generated around a school like Davies from all those new houses, they all pay property taxes. It doesn't cover the cost. It only covers about 50% of the cost of the roads, the street, the water tower, the fire truck, whatever, all that stuff. The school, it covers 50% of it. Who's paying for the other 50%? The people in the older neighborhoods are covering the 50% for the expansion of the new. So then the people in the older neighborhoods who've got potholes in front of their house and need a new sewer line. And guess what? We come along and said, we're gonna have to respecial all of you. And they're like, well, we've been paying property taxes for 40 years. Where'd my money go? Well, it went to the edge. So this is the development system, American style, is not productive in a financial sense to sustain itself. And then everybody runs to Bismarck and says, hey, give us more state money to whatever. And then we subsidize bad decisions, which then lead to some of the health issues. So the challenge, I guess I have to all of you is it's not every day and feel very fortunate that I get invited to come to a health conference and not talk about health insurance and reimbursement models and behavioral health and high-risk pools and all the other things. As we'd spend hours talking about everything we're trying to do to fix there. But to actually come to a health organization, one of the impacts on health is how we design our communities and our culture that drives those decisions. And I know that if we build healthy, vibrant communities, we're going to have a healthier population. We build healthy, vibrant communities that have high walkability, arts, culture, food, all the things brought together. That's going to help us attract workforce. We attract the workforce, then that allows us to have a more efficient communities, and everybody wins. So they're all tied together. Thank you guys. And the challenge, I guess, to all of you is keep thinking, as you're working on health, keep thinking about the everyday decisions that affect all of us around cities that would affect this. And my last thing for you, I was talking about streets and I was talking about roads. If you look at your speedometer and you're going 45 miles an hour, you're not on a street, you're not on a road, you're on a strode. You're on a strode. That's Charles Marone's thing. And if you're on a strode, there's a pretty good chance that the thing you're driving on had a federal subsidy possibly as high as 80%. And if you look at your speedometer and you see that you're going 40 to 45, then look to the side, and what you'll see is big box retailers and drive-through restaurants. That would fit into the food discussion. And you'll know that federal subsidies are influencing the way we design our cities and not in a healthy way. So thank you for having me be here. Thanks again for all the team North Dakota. Thanks, Kim. And thank you all for attending, and have a great evening. Appreciate it.
Thank you so much, Governor Burgum. That was wonderful. As we're transitioning, Chrissy's going to come up and introduce our keynote speaker. But as we're transitioning, we've been talking a lot about health. And many of you probably know this, but research shows that at least every 20 minutes you should change your position, and every 50 to 60 minutes you should stand up if you're sitting, because your brain works better. So as we're doing this transition, what I challenge all of you to do is stand up for we're going to do 15 to 20 second stand up stretch. Jeanne has so much fabulous information to share with us. We want to be sure that our brains are fresh and can take in as much knowledge as we can. So stretch.
I'm going to introduce you. While you're stretching, I will go ahead and introduce our next speaker. As Kim said, my name is Christy Gerard. I am the Health Equity Director for the North Dakota Department of Health. I want to thank you guys all for being here, not only in person, but we have a large number of people that are listening via live stream today. So thank you to you all. So I have the privilege of introducing our keynote speaker tonight. Jeanne Ayres was recently appointed Wisconsin's State Health Officer and Administrator for the Division of Public Health in March of 2019. Jeanne Ayres has been a leader in national efforts to assure health and racial equity and improve population health. She has worked extensively with government, academia, healthcare, community groups, and broad-based community organizers to deepen the public understanding of the social determinants of health and their relationship to race, place, class, and power. From 2011 to 2018, Ayres served as the Assistant Commissioner and Chief Health Equity Strategist of the Minnesota Department of Health. In this role, she led Minnesota's efforts to advance health equity and improve population health. She headed the Health Improvement Bureau and was responsible for the development of the Center for Health Equity. Please welcome Jeanne Ayres.
A more inspiring pre-speaker, since I'm the keynote, I don't know if the governor was, but boy was he inspiring. I was very excited. I'm so pleased to have been invited to join you here today. I am going to, here's what I'm going to talk about. Let's see, did I do it wrong? So basically, I'm just going to talk about health, what creates health, who has the opportunity for health, how power and structural racism affect health. And so that's like one overarching theme. The second thing is I'm going to be introducing a systems approach to creating health, which includes 3 practices. Do I do something? I don't know. Clint, he's got his Fitbit on. Oh, I'm supposed to do something? Okay, and then we'll be really talking about health in all policies. So this is about, it actually a great follow-on to what Governor just spoke about, is that through our policy making, we actually create the healthy communities. So I like the wheat. I want to tell you my own story. So my own story is I grew up on a farm in central Minnesota. I'm 4th generation on that farm. And it wasn't until, he's really great. It wasn't until probably 20-some years into my work life that I realized I had gone into public health because of that experience on a farm. As a fourth-generation farm family, nothing about the way we lived, everything, I should say, about the way we lived together in community had to be figured out with our neighbors. If we were going to have electricity, it was a community decision. If we were going to have a road, if we were going to bus to town for schools, it all had to be worked out. And one of the things was is nobody else was moving away. So it wasn't about whether or not you liked the person, or it wasn't. We couldn't be very partisan because we had to come together to solve issues. And that is actually why I love public health.
How do you build a healthy community? It's more than our genes
So,
and individual behavior.
This definition of public
The
health
environments in which we
is
live, work, and play
really
have the greatest.
that's what inspires me. It's what we as a society do collectively to assure the conditions in which all people can be healthy. And that was my growing up experience. And but really the first thing we have to do is say, what is health? So the definition of health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. It is a broad definition of health. And I want to start with that because there is something about the way we talk and experience the conversation about health that keeps it being about sickness and illness and health care. And there'll be a theme throughout my whole conversation with you tonight that's actually inviting us to talk more broadly about health. And already the governor and commissioner have introduced this. So before I take the next step, I just want to have you yell out to me, and I'll repeat it. What is required for health? What do you think is required for health? Exercise? Sleep? No disease? Nutrition? Water? Housing, a roof? Clean air? Support systems? The World Health Organization names peace, safety, shelter, education, food, income, a stable ecosystem, sustainable resources, and social justice and equity. And that gets sort of close to this support system. Inclusion, being included, having opportunity. These are actually, when we do the data analysis for our data geeks, we realize that health care itself, clinical care, actually only contributes about 10% to our health. And genes in biology that we think, well, that's in my genes, that's again another 10%. The physical environment and the social and economic factors, that's 50%. And our health behaviors, you named a number of them, adds another 30%. But again, you heard a story from the governor about how those health behaviors are impacted by the design of our communities and the policies and systems. So even our health behaviors are part of the broader socially determined factors. So I have 11 people who are going to come up and do a little skit for us. 11 volunteers. And these volunteers, there we go. You want to be do you have a micro? Did you get them here? I guess you. I don't need a microphone. Well, no, you do because we're on a YouTube thing. So speak into this. Somebody was going to bring that. Do you speak into that? Oh, here. No, that's good. She's good. That's it. This is the right way. Okay, they're going to give us 10 tips for how we're going to be healthy. Okay? You stand over here. All right. And these folks are there. She's the whole right side. Okay.
For our first number.
Yep.
All right, can you hear us? Perfect. Us, me and my personalities. All right, these are the 10 tips for better health. Are you ready? Yeah. All right. Don't smoke. If you can, stop. If you can't, cut down. Don't be poor. If you can, stop. If you can't, cannot be poor for long. You should also eat a balanced diet with plenty of fruits and vegetables.
Live near good supermarkets and affordable fresh produce stores.
Make sure you stay physically active and exercise at least 3 times a week.
Live in a safe, leafy neighborhood with parks and green space nearby.
Manage stress. For example, talking things through and taking time to slow down, or planning relaxing getaways.
Work in a rewarding and respected job with good compensation, benefits, and control over your work.
If you drink alcohol, do so in moderation, but don't drink and drive.
If you work, don't lose your job or get laid off.
Cover up in the sun and protect children from sunburn.
Take family vacations and all the benefits you are entitled to.
Make sure you practice safe sex.
Make sure you have wealthy parents.
Schedule regular checkups with your doctor and get screenings for cancer.
Don't live in a damp, low-quality housing near a busy road or polluting factory.
Be safe on the roads, follow the highway code, and wear your seatbelt.
Be sure to own a car so you don't have to rely on public transportation.
And learn the ABCs of first aid: airway, breathing, and circulation.
Learn how to fill out the complex housing benefit application forms before you become homeless and destitute.
Thank you. A hand. So, here, let me get this. Somebody wants this again. So, tell me, what's the true story here? Which one? So, our authoritative person, Sherry, with the microphone, was she right, or was our Greek chorus right? Come on. They're both right. It's all true. It's all true. Both of those stories are true. So, which story do we mostly hear? Sherry's? We hear, and we call that the dominant narrative about health. That's the dominant narrative about health. And the broader narrative about health is actually, so I talk about this in terms of a skill set that is expanding the understanding of what creates health. And I'll share a little bit about why. So the reason it's important for us to expand the understanding of what creates health is that, and let's just read Abraham Lincoln's quote, "Public sentiment is everything, and with public sentiment, nothing can fail. Without it, nothing can succeed. Public sentiment makes statutes and decisions possible or impossible to be executed." So as people, practitioners in the building healthy communities field and public health and commerce, we need to be intentionally expanding the understanding of what actually creates health. because when we have just that one narrow side, it narrows the policy conversation. And this is a skill set, and it is an intentional effort. So the expanded narrative of what creates health is that health is not determined just by clinical care and personal choices. It's also determined by physical, social determinants that affect individuals and communities. And that determinants are created and enhanced by policies and systems that impact the physical and social environment. So the policies and the systems, the environmental design, impact the social, impact the health environment. Health disparities, the differences where some people thrive and some people aren't thriving, are mostly created through policy decisions that are systematically disadvantaging some populations over others. And we're going to come back to that. The definition that I like to use around health equity is that health equity means achieving the conditions in which all people have the opportunity to realize their health potential. Their health potential. That isn't always the same level of health for everyone, but it is the highest level of health possible for that individual without any limitations that are imposed by structural or policy-driven environmental design kinds of decisions. So we want everyone to have the opportunity to be as healthy as possible, and that's what we mean when we're talking about health equity. Health is actually created through a complex system or set of systems that intersect and influence one another. And when we start to talk about this, sometimes it gets overwhelming. People kind of go, geez, did she just say that we have to change everything? How education policy and our environment and transportation and our housing, and does everything have to change? Well, we do have to transform our systems to assure that we create health, but it isn't necessarily through a program. At this point, I really like to introduce the idea of using a systems approach to creating health and healthy communities. And when we talk about a systems approach, there's just some simple practices that we can use to use this type of an approach that you can incorporate into your work. First, we say what? What is the existing pattern that we're seeing? And actually, the governor described a whole lot of patterns about investments, federal investments in roads that then made them larger, that then made the communities less walkable. That's a pattern. So recognizing, having the perspective to be able to recognize that pattern, we say, what is the pattern? And then we say, what is the meaning of that pattern? So what? What is the meaning of that pattern? What is the connection between the pattern that we're seeing and the health outcomes that we're aiming for? And again, honestly, the governor described the connection between the so many different factors and the health outcomes. But then we have to say, what is sustaining those patterns? What is holding the pattern in place? And that's one of the reasons I like to start with the idea about, or the understanding of expanding the understanding of health, because one of the things that holds the pattern in place is our beliefs, or our sort of common dominant narrative about what creates health and what policies are and are not going to help us achieve our aims. And then we ask, now what? What can we do? So first, this pattern. I wanted to recognize, and Mylynn and the governor both mentioned that we had, North Dakota had gone from 18 to 13 on the American Health Rankings last year. And I think that that's really great. There's hardly any state that has moved five categories in a year. Now, it's always important when we're looking at a pattern to look at the whole pattern more broadly. So this is actually the broader pattern. In 1990, when the American Health Rankings started, North Dakota was #1, the healthiest state. And the trend has been moving down. There was a dip around 2008 and 2009, and then still moving down. And then we had that big dip that you've now bounced back from And we should celebrate that bounce back and figure out what made that happen. But number 13 is still lower than number 11, which was what it was 2 years ago. So let's think about the broader pattern, and then what can we do to amplify the positive things and shrink the things that aren't working. So North Dakota's not alone in this. In Minnesota, we're looking at our health data, and the averages on many of our indicators in health data are above average. That's part of our whole mantra. We're above average, and they've really doubled down on that. We really like that's a big piece of our personality of who we think we are. And but when we look at the data and we disaggregate it, we can see that we have some of the greatest disparities between the people who are thriving and the people who are not thriving in the state. In actually, among many states, we have above average differences. Now, I think it's important to think about those differences, because wherever you see a difference, it's an area where we can make an improvement. It's how we learn. If there's a part of the state that isn't doing as well as another part of the state, then we can look, is it a healthcare system? Is it a design? Is there something happening with the water? What's going on? The same thing when you have a population that isn't doing as well as another part of the population. Then we can learn from that. So for me personally, the statistic that brought me into this work was the infant mortality statistics. I just really, knowing what creates health, to know that we have the health inequities around infant mortality. In Minnesota, an African American or Native American infant has more than twice the chance of dying in the first year of life as a white baby. More than twice the chance of dying than a white baby. In North Dakota, American Indian baby, 3 to 4 times the chance of dying than a white baby. Now, I'm saying that because I want to remind you of where we started, about what really creates health. Our social policies, our investments, our opportunities, our environment, that's what's helping us create health. So the other thing about infant mortality is we use, and I look at that statistic and we use it from when we compare nation to nation, because it's one of the most sensitive statistics or data points in terms of telling us not only how are we doing right now, but where are we headed? How are we going where are we going? So the health disparities of infant mortality are really just the tip of disparities. That pattern of who is and is not thriving shows up on every single one of our indicators. In Minnesota, and what am I talking out of? I'm telling tales on my own data, on my own place, right? But every single one of our data points, we saw the same kinds of patterns between who is thriving and who is not thriving. And so the question is the pattern. How did we get here? The disparities are not simply because of a lack of access to care or poor individual choices. They're actually mostly the result of policy decisions that have systematically disadvantaged some populations over others, especially populations of color, American Indians, GLBTQ, and low income. And they are related or an indication of structural inequities and structural racism. They're actually, the disparities in the health outcomes are actually just a tip of societal disparities in social exclusion, poor housing, poverty, where are liquor stores concentrated, who lives in what neighborhoods, all of these things together, back to this whole constellation of community or policies that we've designed together. So the reason this is so important, and why I'm so pleased that you're leading with equity, you have a health equity champion and leader in the agency and in the governor and in Mylynn, is that when we think about where are we headed and the overall pattern, demographically, we're changing. This country is changing. We are getting older, a lot older and a lot faster. And many states, right now, North Dakota is kind of bucking the trend, but many states that are very rural are losing population. And certainly population is moving. But when you look at what part of our population is growing, in Minnesota anyway, the parts of our population that are growing are the people that we have not invested in the success of. They are American Indian and African American and Latino, and they are a very different, diverse, more diverse, and immigrant communities. That's where the growth in our population is coming from. And the graduation rates, the numbers of adverse childhood experiences, all these sort of traumas that people might experience when social conditions are not supporting health and healthy communities, are impacting the part of the population that is growing, that we're relying on, that everyone is relying on. So it's critical that we look at overall these indicators, these patterns. We have basically created communities of opportunity and low opportunities communities. We have communities where people are, there's economic inclusion and thriving small businesses and financial institutions and good transportation and home ownership and all of these things on the, is it the left? The right for you, my left. And then we have created these low opportunity communities. And the high opportunity communities lead to good health status, and the low opportunity communities lead to poor health status. And we can map it all out. It all is correlated. You can see these things. And when you can guess who lives in which of these communities, then you've got to ask whether structural racism is at play. So when you can predict who is living in the high opportunity and who is living in low opportunity, then you've got to kind of, as a pattern, think, what is it about the way we're structuring and making decisions that are creating more and less opportunity? So we had the opportunity to look into this further in the Minnesota Department of Health, and we wrote a report for the Minnesota State Legislature on advancing health equity, and we asked a set of questions. And actually, after this meeting, you're going to get a handout that has some of these questions that we asked. Things like looking at the existing policies and what are the outcomes, and anyway, they're really good questions for interrupting our practices and thinking about our work in different ways. Sorry. So here's an example of how structural racism works, because generally when we bring this subject up, it creates some tension, and at least it certainly did in our agency and with a lot of our partners. So we looked at the data, and in Minnesota, 75% of white population owns their own home, and 21% of African Americans own their own home. Now there's a whole lot of historical reasons around redlining and opportunity that made that be the case. But the way this showed up in our public health work, our environmental health team was going through this set of questions and went, oh my gosh, we designed our radon protection program around home ownership. Is that structural racism? And yeah, that's how it shows up. I got to tell you, when we had that conversation, people were very upset with, and here's where we got hung up. We didn't mean it. It wasn't our intent. It isn't our fault. It's not really a helpful conversation. The helpful thing to do is to say, oh, we just discovered this. How do we change it? So we reached out and we began to do outreach in different ways with our radon program. We told this story to our Biomonitoring Scientific Advisory Committee. I love that name. Anyway, I told that story at the meeting of that set of external advisors, and they went, oh my gosh, we designed our biomonitoring program for testing for PFCs and PFAS and all that stuff around home ownership. Are we doing it? Do you know, so then we redesigned our research design so that we specifically did extra outreach to reach out to people who were not homeowners to be sure they got engaged in the biomonitoring. We had our staff, we had a safe harbors program for people who've been sexually trafficked, and our staff wrote the RFPs, and many of you are in public health, so you know how this works, and they went out in public, and then people applied for the money, and we led with a set of assumptions, and this is one of the questions on this list. What assumptions? Identify the assumptions and whose values are underlying this process. You know, we led with the assumption that it was critical that we have statewide coverage. And so we did. We had grantees from across the state, and no one equipped to work with the American Indian community. And the American Indian community in Minnesota was the highest trafficked population. So, but because we had begun this sort of process of questioning ourselves, we were able to stop, even though we were reviewing grants, stop, get the tribes on the phone and say, how do we go forward from here? Let's interrupt our process. How do we go forward? Because we can't wait 3 years for this grant program to be over and then do it better. We can interrupt it right now. So that was, that's a set of examples of structural racism and how it played out in our work. So this is kind of a quick summary of when you look at the pattern. Let's talk about the pattern. Our health is almost completely connected to our living conditions. And our data's been saying this for years, and we've all said it today. But there was something missing in this picture. Because those living conditions are shaped by a set of forces beyond the control of the individual and include economics, the distribution of money, power, social policies, and politics at every level: global, national, state, local, organizational. So it's like, and this is the policy piece of this. This is what they mean. This is what we mean by social determinants. There's something beyond just our health being connected to our living conditions. Our health is almost completely connected to our ability to impact those conditions. So our capacity to act, our power. Our health's almost completely connected to our power to, back to that definition of growing up in my community, our power to make decisions together that will assure that we all thrive. And so when we go back to the systems approach, this gives us a complete cue. That's part of the pattern. What is the pattern? We have different groups, different places, different populations with different ability to influence the conditions. The meaning of that is that we will continue to have health inequities unless we change that pattern. So we get to the third step of using the systems approach, and that is now what? What can we do? And this is the most helpful or hopeful, I should say, part of this process to me, is that we can change the pattern in a system. We can change the pattern in a system with 3 to 7 simple practices. So this is a big change for us in public health because we're always looking for some money for a program and an intervention. But that's rooted in the understanding of, or the thinking that our health can be fixed that way. But if you realize that we have to transform these relationships and build our collective capacity to impact the conditions, then what you can say is, what are those three practices? The 3 practices that help us intentionally build our collective power are expanding the understanding of health. That's called organizing the narrative. Expanding the understanding of what creates health to include the opportunity for health. The second part is strengthening the capacity of communities to create their own healthy futures. And that's the processes and the partnerships and meetings like this across sectors and agencies and interagency work and work with local partners and state partners all together. And that's called organized. In community organizing parlance, we would say that's organizing people. So that's organizing narrative and knowledge and the data, and then organizing people. And we implement a health in all policies approach with equity as the aim. And that is organizing not just money and resources, but how stuff works. So how the RFP process worked, who's informing the process. I mean, all of that, how those systems and places work. Those three practices can change a pattern. And we began to sort of put them together as the triple aim of health equity and said when these three things are working, it creates social cohesion, resilience, community capacity, community agency. Political scientists have a whole lot of different terms for it. But that was just to make it easier to explain. Did that help? Anyway, the Main Street Initiative, what an inspiring vision and plan. It is exactly, I talked about expanding the understanding, and our skit did that. But the governor actually, and Commissioner Kommer, actually described key elements of strengthening the community's ability to create health. But one of the things that when I was looking ahead of time at some of the literature what the governor had written about, was that one of the values, some of the values that were lifted up in that initiative is a respect for the past. And I want to name that because I think we have to respect the past, both what's worked in the past and the past in terms of how we've structured our relationships and policies that haven't worked. And he gave a number of examples of ones that weren't working around physical activity and thriving communities. But we have, and I've given some examples of policies that are disadvantaging populations. So that respect in order to reach our full potential. And then partnering with leaders across the state to ensure the tools and programs to lead to the strength and the power to decide. So the kinds of tools that we have that we can share across health and various sectors are data collection and analysis. We have some great takers who will be very interested in our data. And reports, white papers, bully pulpit, stakeholder sort of scan and analysis, who is at the table, who also needs to be here, whose voices are being considered, who's helping decide, and asking questions, this set of questions that we'll share with you, and again, this health in all policies with health at all levels, with health impact assessments as a tool as well. So the health in all policies, the definition of this, it's sort of a, I don't know, is it a term of art right now, but it is basically a collaborative approach that integrates and articulates health considerations into policy making across sectors at all levels to improve health of communities and people. And it's important to have equity as the aim in this process, and I have a story I can share about that. When we talk about policy, it's a law, it's a regulation, it's a procedure, an administrative action, or a voluntary practice. It can be government or private sector, and it affects groups or populations, and it also influences resource allocation. So that's how we're thinking and talking about policy. So it's really broad. It happens, it's how we structure our lives together in so many ways. How are we on time? Because this is a 4-minute thing, and actually the governor talked a little about this already. Should we watch this? All right, is Clint there? Hit go. You can do it from up there. You don't even have to run down here again.
How do you build a healthy community? It's more than our genes, individual behavior, or even access to health care. The environments in which we live, work, and play have the greatest impact on our health. To build a healthy community, it all starts with our environment. We need healthy food, clean air and water, parks for recreation and play, safe transportation for people on foot or bicycle, or in cars or transit. tobacco-free places, indoors and out, affordable homes close to daily needs, communities that are safe and free from violence, jobs and opportunities to invest in our future, healthy schools where our kids can learn and succeed, a feeling of connection with our neighbors, and a strong sense of community. Our health is affected by the places we live, work, and play. But how can we create healthy environments? Experts like the CDC agree that the best way to achieve health is by changing environmental factors. And to create change, there must be policy. Policies provide the framework for building healthy environments. Policies put healthy foods in neighborhoods by financing grocery stores and cutting red tape for farmers markets. Policies create parks and well-maintained places to play. Policies make it possible for us to safely walk or bike to meet our daily needs. Policies ensure we can breathe air free from toxic secondhand smoke. Policies create affordable housing and ensure that our homes are safe and healthy. Policies can promote public safety through well-lit streets. Policies make sure that jobs are accessible by transit and pay a living wage. Policies support healthy schools that kids can walk and bike to, that serve nourishing foods, and that offer spaces where the whole community can play. Individual policies can improve our health in many ways. For example, laws designed to curb tobacco use have saved millions of lives. However, policy doesn't often take health into account. We have made uncoordinated changes to our environment through isolated policies, which prevents us from solving our biggest challenges, such as violence, poverty, chronic disease, and climate change. For example, a Parks and Recreation Department might build a new park, which raises the price of nearby homes. When park policy is disconnected from housing policy, some residents won't be able to stay in their homes. Or the Transportation Department may expand a roadway, which increases the number of cars on the road. Without a policy to design streets for people to safely walk, bike, and drive, community leaders miss opportunities to reduce congestion and improve health. What if we could change it, working together to tackle our biggest problems? What would it look like? It would mean a new approach, health in all policies. You might call it sustainability or wellness in all policies, or even equity in all policies. But it all means one thing: bringing public agencies together around a common goal. We must adopt a new approach that changes how we make decisions so that everyone is working together to build stronger, healthier communities. This approach requires leaders from public agencies to convene and collaborate, to engage the community and create a vision for a healthier community, to make a plan for how we achieve this vision, to implement that plan by investing in change, and to track progress to see what has been accomplished and what we still need to do. Join the movement to create healthier communities. Visit our website to learn more. How do you build a healthy community? It's more than our genes, individual behavior, or even access to health care. The
So the
environments in
kinds
which
of
we
questions
live, work, and
when
play
we're looking at
have the
policies,
greatest impact
and they
on our
named
health.
all these different
To build a healthy
sectors, is
community,
we ask what's
it all
working,
starts with our
what
environment.
policies and practices
We need
and
healthy food,
processes are creating
clean air and water,
inequities
parks for
within our
recreation
you know,
and play,
so
safe
what are we
transportation
doing that is
for people on
actually
foot
creating
or
those
bicycles,
differences,
or
like
in
the-
cars
like
or
our
transit,
team
tobacco-free places,
identified and I
indoors
shared.
and out.
And then we
affordable
identify
homes
areas
close
where
to daily
where
needs,
the structural
communities that are
inequities
safe and free
are
from
creating
violence,
different
jobs and
outcomes.
opportunities to invest in our future.
And then that helps
Healthy
us
schools where our kids can learn
create
and
the
succeed.
the
A
accountability
feeling
for a
of
different set
connection with our
decisions.
neighbors.
So
and a
it's
strong
actually a muscle. It's like a collective muscle. We have to practice it together. Each one of these practices works that way. So I'm just going to look at a couple of different health challenges for North Dakota and all of the country, basically. But if you look at the self-reported obesity rates, I don't know how many of you have looked at obesity maps, but we had to come up with new colors because they were getting worse, you know, so over the last number of years. But this is the map from 2017, and the obesity rate in North Dakota went up from 29.7 to 33.1%. The trend is not the direction that we would want. And in fact, if you look at what was going on in all these states, Minnesota was tracking with the other parts of the Midwest here. And in 2008, we passed a statewide health improvement partnership initiative where we began to look at the policies, the system, and environmental change in communities across the state that would increase physical activity and nutrition and tobacco prevention as well. And so the kinds of policies, and first of all, this is not, nobody, there's a lot of debate about whether or not that led to this yellow moment. But it is one of these aspects that we have to consider. What is different about these places? What is different? What can we learn? So one of the, these are the kinds of policy arenas that there is a set of evidence, and I put a link here for CDC. They have tons of different strategies and evidence-based strategies, but it's around the built environment and planning and transportation and housing and increasing physical activity in the schools and childcare and communities. Healthy food, we have a food charter that we developed that I think addresses some of the food accessibility and the fact that we're agricultural states and we're not able to get food. That's just something that we can change. And did you guys know, here's something I learned when I was running around the state and talking to people. Did you know that a number of years ago, to save money, our schools they took all the stoves out and the ovens and stuff. Did you know that? They buy the food, many of our school systems, to save money, just buys food in big trays, unhealthy food, and they pop it in to heat it up. And so we had to, part of this SHIP program that we had, was to help schools re-equip their kitchens and their cooks so that they could cook vegetables. And then we hired, some of our counties got together and hired food foragers, which I thought was the coolest job. They basically, if you're going to have healthy food, like fresh food in schools, you got to have somebody planning where it's coming from and how to get it into the school. And so that was like a job, but these are the kinds of things that are in that. So here's another pattern to look at. The black-white gaps in child poverty are some of the biggest in the upper Midwest. These are the states that are the worst. Now, we know a lot about child poverty and what it means for health. We know that we are actually, did anybody, I read a study once that people who were homeless, even one period during their childhood, have more colds when they grow up. Our trauma from our early life gets embedded in our bodies and in our brains, and it shows up in many, many ways and places. These are the kinds of policies that the Roadmap for Reducing Child Poverty has listed, but expanding the Earned Income Tax Credit, Child Dependent Tax Credit, SNAP, housing vouchers, increasing the minimum wage. We were able, as the health department, to write a report about the connection between income and health, and the community partners were able to use it to expand the conversation about minimum wage in the state to include health considerations. And the same thing with paid leave, to include the health considerations. And elimination of immigrant eligibility restrictions. These are on that list from the Child Poverty Reducing Roadmap thing. So the questions that we ask are: who benefits from a policy? What health impacts? Who is being impacted? What and whose values and beliefs and assumptions are operating? What's the outcome versus the intent? Back to how the people in our radon program felt. Very overwhelmed to realize that they were part of creating an inequity. And this isn't about intent. This is about when we recognize the outcome isn't what we want, let's shift and do a different thing. And we can ask whether or not we need further study. I want to say a few words about why it's important to lead with equity. If we don't lead with equity, we can increase the inequities. And I had one community that was doing all this cross-agency planning and was so excited about doing a complete street sidewalk project, and they had planned the sidewalk to go by a affordable housing complex. And this is a medium-sized town. And they got to the city council meeting, and they were like, yay, we got the money, and we're going to expand the sidewalk. And the building owner showed up and said, I'm not going to plow that. I'm not going to maintain that sidewalk. And the city council said, okay, well, let's put it over here. And they moved the sidewalk and invited me to an event 5 months later to celebrate the success. This was not leading with equity. If they had showed up at that meeting with the two moms with the strollers or somebody who is disabled, I mean, if they had showed up with anybody who lived in that complex, they would have had a different outcome. So it's about strengthening the community, engaging the people who are most impacted, and leading with equity. And if we don't lead with equity, we can be creating additional barriers to targeted investments. We're decreasing the power of the communities that are most impacted. We aren't building trust, and we are decreasing our overall effectiveness. And that's why it's important. And to just all three of those practices together, expanding the narrative and and using health in all policies, help strengthen our collective capacity to assure the conditions for health. Overall, these are the lessons that I can take away from the years of doing this work. One is that it's organic work. It has to be interwoven with all of the other things we're doing. It isn't necessarily a program. It has to be intentional. It requires a commitment. It's just wonderful to have the commitment from the leadership in the state for this work. And it is a commitment to building our skills and holding ourselves accountable. And it is imperfect. It's imperfect. I don't know what your agencies are like, but where I have been working, the fear of not being right or knowing the answer before we start and or having enough resources to completely finish the project, it keeps us from moving forward. This isn't that kind of work. We can't do it that way. That's why I wanted to talk about a systems approach. It's 3 practices. The practices, you use them to amplify the pattern that you want, and we work to shrink the patterns that we don't want. So the next steps are amplify the broader narrative, identify and intentionally influence the policy and patterns of decision making, be an ally to the communities that are experiencing the greatest inequities, and explicitly commit to addressing structural and racial inequities. And that's it. It's charting a course in North Dakota right out to the reception. Here's my one of my favorite quotes. Public health is the constant definition of the unacceptable. And so we're at a moment, a really cool moment, where we get to say, it's unacceptable, these inequities. It's unacceptable the way we've created these health changes. The people in the United States did not just change physiologically in the last 30 years and become obese. Our communities and our policies and our food opportunities, we're a function of what has been available to us. So, there. I've got resources at the end of this. I think they'll probably share this PowerPoint. Do we have any minutes for questions?
Were there questions from the live streaming? Questions from the audience?
Does this work? Oh, there we go. We have people live streaming, so we have to make sure that the questions come through the mic so everyone can hear.
Hi, everyone. Thank you so much. I'm Karen Ayres. I'm the coordinator for Creating a Hunger-Free North Dakota. And I think it's unacceptable that we have things going really well in the state, but there are communities and people in our state that are experiencing hunger and food insecurity. So thank you for giving us the lead in how we talk about these things. Also, the group that experiences the highest disparities in health, there was one person here, I think she had to leave, who is from that population of American Indians. Representative Ruth Buffalo was here in our audience, the only Native American woman serving in our legislature. So I think we just need to think about and make sure that we're including everyone at the table.
Hi, thank you also for your talk and information. My name is Taylor Sievertson. I'm from the Great Plains Food Bank, and we have certainly started to engage in this work of collective community impact and trying to really pull together cross-collaborative organizations and finding our way into the systems that have created disparity. And my question is, we know that work is important, and all of us individually recognize that. And I'd ask, what's the biggest challenge that you've recognized in getting those people to the table, leadership in organizations, and getting them to understand the issue at hand and be willing to commit to it?
Say a couple more words about when you said these people. Were you talking about the people most impacted by a health condition, or are you talking about
decision makers? How, we're recognizing some challenges in getting those people to the table who...
How do you get people in positions of influence to embrace this broader understanding? Well, that's why it's important to build our collective power, because that's the most influential aspect. I mean, one of the challenges we believe deeply that if we just explain it, somebody will then do good things. We bring the data, and then we're going to explain it. And then if they didn't do the policy that we very clearly know should happen, well, maybe we should put that in another report and make it bold. I mean, this is basically our approach. And that's not how community organizers work. So I spent a bunch of time with community organizers because my public health field was not informing me on how to build collective power. And these three practices of organized people, organized resources, and organized narrative build power. But they're very tight, they're interconnected. So who you're having the conversation with and strengthening the capacity of the community to help carry the message is critical. Now, in public health, I know we have so many levers around the expanding understanding, but we also do around convening. And when you have partners like Kommer and the Main Street Initiative, you have even more convening capacity. So then your data can be part of expanding the understanding and pointing the direction to the policies. But it isn't a matter of just like showing up, and people who are busy, influencers are busy, and they listen to the people that got them there. So that is critical. That's just, and it's about changing the pattern. So there was do I have time for a quick story? So when we were going to, maybe it isn't even quick, when we were going to write the Advancing Health Equity Report, we realized we had to lead with race. And many people told me we can't talk about structural racism in a government report. People will cut your funding and they're gonna be mad. And I said, when we're done, it won't be our report. when we're done, it won't be our report. We had 100 people from the Minnesota Department of Health who carried parts of that report. And at the end of it, like we had a launch day, and I said, who are you in relationship with that you can have this conversation with this set of questions in the next 6 weeks? And they committed to 150 convenings and or advisory boards and or conversations. And 1,000 people wrote that report. 1,000 people wrote that report. When it was done and when it came out, we led what we said. Structural racism is, actually a health threat in Minnesota. But it wasn't me. It was 1,000 people, and they were having their own press conferences. And they were having their own meetings. And basically what we were doing was amplifying a story that was true, that was happening, and other people could use our partnering with them to do that, to be stronger. And that's how you get people to the table. You imagine doing it with more people. I think that people want to go to the reception. So thank you. Oh, I'm sorry. You guys had stuff to say.
No, yeah, just real quick. Thank you, Jeanne, for that fantastic information and very important information. I hope the information resonated with you as much as it did with me. Some of the words that I took, words and messages that I took with me is equitable opportunities. Policies can impact. Collective power. And then also I learned, and I hope you all learned too, that through our leadership, our wonderful leadership, better understanding, expanding the understanding, and communicating, and through our partnership, we can make a difference and we can advance health equity here in North Dakota. So now I get to invite you to take the next steps towards action, and that's by joining us at the networking mixer that's being hosted by North Dakota Association of Counties, North Dakota League of Cities, our Economic Development Association of North Dakota, and then at the networking mixer on the tables we have table tents, and one side of the table tents has actions that you can consider. And I should probably read those because I think we still have some people live streaming, so you too can consider to take some next steps. One of them is we have 2 reports on the tables, and one of us the county health rankings document, and the other is the health disparities report that Chrissy's going to talk about. And so what we're asking you to do is look through that data and share that data with your community partners you work with, community members. Next, we're going to ask you to partner with community and state leaders and talk about some policies that you can make a difference around. And then the last one is identify 3 to 5 leaders from the legislative committee or your agency or your community to explore how to advance health equity through health public policy. And then, as I mentioned, on the other side of them, you're going to see some health equity tidbits. So take some time and look through those and have conversations around that. And then just a little bit about one of the documents that is on the table, and we'll make sure we get the links to those that are live streaming. This is the County Health Rankings report, and it was generated by the University of Wisconsin Health Policy Institute, Population Health Institute. And this document, the data in here, it does exactly what Jeanne was referring to. It helps us to identify the patterns. So we can see what is causing disparities, where the disparities are, and we can dig deeper and try to strategize of how to improve on that. And I will turn it over to you.
We'll just dance around a little bit. So as Kelly said and Kim talked about a little bit, this is the 2017 Health Disparities Plan, and they will also be located on the table. Feel free to take a copy, look through it. There's also a fast fact sheet that'll be out on a table there, and feel free to take those as well. This report talks about the top 10 causes of death and the top 10 infectious diseases in North Dakota, and where those inequities are in those diseases. And our plan right now is that by August of 2019, we will have finished a strategic plan to address those disparities that were identified in that report. So the finalized plan will be done sometime this fall, so stay tuned for that. And I know that we are the ones that are standing between you and food, so we will wrap this up. But again, I want to thank all of you for attending. Thank you to our speakers, and thank you. Have a good night.